Morning, everybody, and welcome to our webinar this morning on motor neurone disease in the palliative patient. I'm Celia Palmer, I'm Clinical Director at Hospice West Auckland, and I'm going to be joined during the presentation by other members of our team, Grace, Charlotte and Ella from our nursing team, and Jen Mercer from our rehabilitation team. So I'll welcome those later on in the presentation. Just a reminder that if you do have any questions for myself, for other presenters or the panel, please do use the Q&A function. And if you have any general questions which aren't content related, then please put those in the chat function. We are recording the webinar, so it will be available later. I'm going to start this morning with karakia. Tuia ki runga, tuia ki raro, tuia ki waho, tuia ki roto. Tuia te here tangata, ka ronga te po, ka ronga te ao, homie, huie, taiki. When I was thinking about preparing this presentation, I thought how hard going to see somebody with motor neurone disease is. And I think for many of us, it's a heart sink diagnosis because we know how tough it is, both for a patient and the family around them. And also in some ways for us to provide the sort of support that we would really like to these families. So I hopefully throughout the presentation, through showing you some of the cases we've been involved with, we'll have more of an idea of how we might best support these patients. I'm going to give a brief background introduction to MND before we talk about a number of cases. So MND is a rare disease, probably only 1 to 2 people, 5 to 6 people per 1,000 population, 100,000 populations its prevalence. And every year you'd expect 1 to 2 new people diagnosed per 100,000. So GPs would only expect to care for maybe one of those patients during their career. And for most patients, it's just occurred, it's sporadic. There's only a small percentage, around 10%, for which MND is genetic. It's a progressive neurological disorder presenting with, and the interesting thing, it presents with lower motor neuron and upper motor neuron signs. And the result of that gives you the sort of picture that you see in motor neurone disease. So what's actually happening in the body? You get, this is showing one of the nerves heading down to innervate a muscle here. And the nerve becomes damaged with its scaffolding breakdown around the sheath so that it can only transmit much slower the messages it wants to give. And also you get changes in the cell itself, where there's toxic proteins are built up from changes in the buildup of glutamate. So these are the sort of pictures that you'll see with as well shortened endings of the nerve, so that again less contact with the muscle fibers and less innervation happening there. So people present depending on the sorts of signs and the sorts of problems that they generally have. So if they're predominantly upper motor neuron signs, they're more likely to have spasticity with hyperreflexia and clonus. If they're mainly lower motor neuron signs, you would have more muscle weakness and wasting. The reflexes are low, and they might get fasciculations as well in muscles. So the distinguishing thing of motor neuron disease is that you get both of these things present. In some cases, people present with signs of brainstem involvement, where they might have problems with speech or swallowing to start with. Others start with the respiratory involvement, with difficulty breathing being the predominant symptom. Occasionally, a small percentage are presenting with a dementia, frontotemporal dementia, and that can become very quickly progressive. I do think that this is sometimes the place where MND is most misdiagnosed, because it's quite difficult to identify the problem. So the main way that we investigate whether somebody has MND is through clinical history and examination, and that, as I've just explained, around the motor neuron, upper and lower motor neuron signs. Electromyography, where we check how quickly impulses are going along the nerve, and that's probably the most important diagnostic test. They may also have MRI or PET scanning, genetic testing, and possibly neuropsychiatric testing if there's a suspected frontotemporal dementia. So I'm moving to one of our polls. My first question is, what is the average life expectancy of someone with motor neurone disease? Is it a year or less, between 1 and 2 years, between 2 and 5, or more than 5 years? I'm just going to give you some time to think about that. I'm not allowed to vote, so waiting to hear yours. So most people said between 2 and 5 years, which is absolutely right. There is obviously a wide variation in this, but the average life expectancy is between 2 and 5. Okay. Generally, the last year of life in MND is the one year we get involved as palliative physicians and teams. And for patients with MND, that can be a very difficult period. Often there's rapid and significant losses in function, in independence. There's lots of contact with the health system and often many different people within the health system, and significant carer and carer stress. Just like these pictures just illustrate, I think, one, how patients with MND there's often a lot of equipment needed in the house. There's always needs to be a carer there, and you can see in each of these photos that's reflected. So I'm going to move on to our cases so that we can reflect on these and particularly their differences. I think it's quite interesting to see. So Chris was a 58-year-old man. He was married and living at home with his wife. He had 2 children, well, young adults, 28 and 31 years of age. And he presented to neurology about 3 months prior to when we saw him, with new back pain and progressive weakness of his limbs that was painless. He had no numbness or paresthesia, and he'd also noticed for a couple of months that he had twitching around his body. So the diagnosis of motor neurone disease was made with predominant lower limb weakness. At that stage, on diagnosis, he didn't have any problems at all with his swallowing. He didn't have problems with breathing, even though his exercise tolerance was reduced, and he had reduced reflexes in his lower limbs. He had the initial diagnostic testing we've talked about, nerve conduction studies. He had genetic testing, which was negative, spirometry, chest X-ray, and MRI scans. And often these patients need, right at the beginning, referral to physiotherapy and/or occupational therapy. So the nerve conduction studies did confirm the diagnosis, and he was started on riluzole at his request. Riluzole's a drug that's been relatively new, but is now standard, certainly offered to all our motor neuron patients. It has got side effects and complications in terms of it's contraindicated in liver problems, and the person would also need to have frequent liver tests. And in very small number of cases, you can get a complication of interstitial lung disease, which also can be confusing to diagnose in the case of MND. Chris was also started on an antidepressant, and it was only 5 weeks after his diagnosis that he was referred to palliative care. So a question about riluzole. How long would people say that it extends survivorship? Is that 1 month or less, more than 1 and less than 3 months, between 3 and 6, or more than 6 months? Just giving you time to answer that. I'm going to take either B and C as an answer for this because it was the literature is quite challenging, and I think on the verge of 3 months, but 2 to 4 is also often quoted. So I think for some patients, they don't feel that that's something that they want to take on with its challenges and the side effects and the life expect and the extended survivorship being relatively short. Our patient Chris, however, did decide to take riluzole. He did have a rapid deterioration in his mobility and quickly needed walking frames within the house, had difficulty getting up out of chairs, was unsteady on his feet and prone to fatigue. At that stage, he hadn't got any respiratory involvement at his referral, and his speech and swallowing were fine. There was a very slight reduction in his mouth pressures, expiratory mouth pressures, but generally he didn't have any respiratory symptoms at that stage. This is only 5 weeks later. He had a significant decline in his respiratory function test, progressive weakness of his legs, he was now in a wheelchair. And he had this shallow breathing when he was lying flat, but hadn't noticed anything else. However, his lung function test showed a restrictive lung defect. His FVC was 59% of predicted. Generally, one of the reasons that people get started on BiPAP, which if it becomes under 60%. So he was started on BiPAP at that stage. So just a question about providing non-invasive ventilation in patients like this. Do we think that what do you think the median survival if they choose to have survival benefit, if they choose to have NIV, would it be less than a month, 1 to 5 months, 6 to 12, or more than 12 months? Okay, we've got quite a range here, and most of the literature would say that around 7 months, so 6 to 12 months. However, there is a big variety depending on if people have got, as I've said here, preserved bulbar function. So for those patients, it's around 7 months. Obviously quite different if they have got involved bulbar muscles. So one of the issues Chris had was getting a suitable mask initially. He found that really difficult to manage, and there is a range of masks that people can try, and he was most suitable for the nasal mask, which fitted him well. At first, he was using it all night and maybe for 1 or 2 hours on and off throughout the day. He could sleep with it on, but often he found that really uncomfortable, and he had to reposition himself, woke plenty of times through the night just because of the discomfort. He also, a common problem we find with MND patients, had a lot of discomfort where the straps of the mask were placed. That had to be troubleshooted to make that more comfortable for him. So the problem for him and our other patients with the MND is this progressive diaphragmatic weakness, which leads to a few things. One, the reduced inspiratory muscle strength, which mainly is the one that affects ventilation. Reduced expiratory muscle strength, which also reduces our ability to clear airways and secretions. And if there's bulbar involvement, that also raises the difficulty or the complication of aspiration pneumonia. So Chris increased his use in NIV of his NIV very quickly, and by the time I next saw him, he was using it all night and sometimes during the day, and his total usage was about 9 to 10 hours. In 24, he had increased breathlessness, His family were asked to get vaccinations, and all of us who, they were keen that all of us who visited him wore masks. And at the time, he also had quite a bad cough, which he found difficult to manage and was often associated with eating. So cough is definitely something that we see often in these patients. As I've explained, it does require quite a lot of inspiratory strength to take the breath in, then glottic control to close the vocal cords and build the pressure, and an expiratory force to push the air out, and uses these muscles, all of which can be impacted in MND, the diaphragm, intercostal muscles, vulvar and abdominal muscles. So the result is often a weak or ineffective cough and coughing after eating or drinking with recurrent chest infections. So what can we do about that? Well, I think one of the ways that we can help with is chest physiotherapy, but also mechanical cough assist devices. We're lucky enough to have a cough assist device. And at that stage, we did refer him to our physio, and he was set up with this device, which he found particularly helpful in his case. Otherwise, we also need to manage secretions, provide, and maybe there's different settings that we can provide to the NIV, which will also help management of the cough. So Chris had a very rapid decline, and after only 2 months, he was using the mask day and night. He could only at this stage take the mask off to eat, and he was just managing a few spoonfuls before having to put it back on. He had several discussions with us at this time about how he would like to have the non-invasive ventilation removed. He was deteriorating at this stage every few days, and he didn't want to put his family through an unplanned his own respiratory difficulty unplanned at home, where he felt that that would be very traumatic for them. So he was able to die at home with his family after appropriate sedation, and we also set up a syringe driver. And this is something which actually is complicated, and I'm not going to go into it too much detail in this webinar, but it definitely needs specialist advice and support in order to safely and comfortably remove the NIV from one of our patients. I'm going to ask Grace McGonigal to join us now. Grace was involved with Chris and supported him throughout his journey, and I'd like to ask her to comment on the case and anything particular that she learned from it.
Thanks, Celia. Yes, Chris was in a way quite challenging. I've cared for other MND patients, but the rate of his progression and deterioration was quite significant. A few takeaways I took from caring from him was the real person-centered care and what was important to them. I remember quite clearly on Celia and I's first visit, you could sense the grief in that room. It was quite heavy in grief of the loss of their future, the loss of their dad, and the changes they see in an almost weekly basis, and allowing them to, and being okay for us to almost sit with that grief with them. There was, I think Celia touched on this, there was certain aspects to his care which was quite important, I think, and it kind of encompassed the concept of person-centered care, and there were a few specific things that they really needed, and that was obviously for us to ask, for us to wear masks, and the second was not to ask how they are, because they were not good. And I think us naturally being like, hey, how are you going, or coming in bright and chirpy, that kind of amplified their grief in a way. So also being aware of our own impact on their emotional well-being. I also found that allowing them to have space to grieve, and also just offering them some emotional support in the way they found helpful. They didn't want counselling from us, but we did connect the wife with massage, and I think that really helped. And I felt like this was a part that maybe I didn't have a lot of confidence in, is supporting this emotional, psychosocial element and navigating and helping support them through this. Another thing that kind of came up through these discussions of kind of person-centered care for them was the workload that healthcare professionals, especially in MMD, where there's several healthcare professionals involved, is the workload we do consciously, subconsciously place on people and their families caring for a long-term condition. Their home was a place of refuge, a place of respite. They didn't like people coming into their house very much beforehand, and they didn't like it even more now. And they were having carers in several times a day, plus us, plus occupational therapy, and plus physio. And it was a lot for them, and just supporting them through that, and trying to minimize the impact of that workload as much as we can. Another thing that Celia brought up was the amount of equipment people require, and just being mindful of that as well. This wasn't a very big home, and it almost goes from 0 to 100 very quickly, right? So we were just quite mindful of that, and everything was a discussion, especially but definitely the best equipment we put in was the cough assist machine. That I felt like that really made a big difference to his quality of life. One thing I've also found in caring for people with MND, and particularly with him, is kind of around the management of physical symptoms, and particularly the challenging aspect is bowels. And I do apologise about talking about this at 7 minutes to 8 in the morning. But for a lot of people with MND, stimulant laxatives are actually really painful and almost add to that already pre-existing cramping that they get with this condition. So we actually found osmotic laxatives probably the most beneficial in managing it. And we also know that bowels, urinary function, that whole pelvic system runs really well on regularity and consistency and habit. I found this quite a troublesome area to care for him in, and it took a lot of research. There were some nice guidelines around it, but not a lot. So that's where you can draw experience from pelvic floor physios who deal with continence as well, and bowel management, and also just the continence service. Often I found with some of these guidelines or suggestions is it was guidelines based on the perfectly functioning healthcare system, right? Where we all had equitable access, equitable opportunities. But a lot of the time it was also drawing on expertise from the MND. Sally King, we had a really good discussion with her, and drawing from her practical real life experiences of caring for these people. And realizing that sometimes it is a bit of trial and error. But yeah, his care was, I guess to summarize, was just quite impactful, and also just being aware of our impact on people, and working in that more person-centered care, because as Celia will probably go on to talk about, these 3 different cases are very different, and how you manage them, and including that psychosocial element. I'll pass it back to you. Thanks, Celia.
Thanks, Grace. Yeah, I think that one of the things I remember when I first went to see this gentleman with you, as you said, it needs to be at 11. And so that's where I think it was you made that more person-centered, because for them, and I think for many patients with MND, the routine that they have is very important to follow. And for this family, there was no other time. We had to come. We came at that time, and that was fine. That suited them and suited his routine. So I think that was you that instigated that, which I think was really helpful for them. Thank you, Grace. Big thank you. So I'm going to go back to my slides and introduce Nigel, who was our second case. He was diagnosed back in 2015 and referred to us a couple of years later. And during his time under Hospice West Auckland, he went from actually playing football and having difficulty walking to 24-hour cares. He went from having good nutrition to using a rig, from breathing independently to being 24 hours a day on NIV, and from talking to us to being on using a communication device. So Grace briefly touched on the people involved in care of somebody with MND, and I think that this is usually quite a big multidisciplinary team that we need to involve. And I think constant communication with the team is really important, because everybody's got their contribution to make, which can make a difference to this person and their family. So Nigel was very, very proactive about his management. So he had a rig placed for enteral feeding. At the time, he wasn't well enough to lie flat, which you need to be able to for the pig. So he had a rig placed, and he was having 24 hours a day BiPAP. He also was referred to TalkLink to have equipment to help him communicate. And he used a machine which looked at his eye gaze to communicate. He used a power wheelchair when he could. He had hoists to help him in and out of bed. He had a neck brace. I would say that when you went into his room at home in the last few months, it was really like going into an intensive care at home, with the amount of equipment that was in there and that his wife was managing. So let's just take a segue into enteral feeding. We know that malnutrition predicts worse outcomes for patients with MND. What we don't know, though, is whether a PEG or a RIG extends survival time. However, usually enteral feeding via PEG or RIG is standard and usually offered for refractory dysphagia and weight loss, although not everybody takes that up. Also, the importance of early dietetic input and weight maintenance, due to the fact that this malnutrition does worsen outcomes. And there's a number of things that influence PEG uptake, and often that might be respiratory status. If respiratory status is poor and they can't have a PEG, then they can have a RIG, which is radiologically induced and does not need the patient to lie flat. Sometimes the patient decides that they don't want enteral feeding, and that's their own choice, and depends on their own values and wishes. So what percentage of MND patients do you think have got a PEG or RIG in situ? Would it be under 20%, 20 to 40, 41 to 60, or over 60? I need to do a lot of polls today. So it's actually 20 to 40% who do have that inserted. And I guess that would be for a number of reasons why they wouldn't have that, but particularly probably patient choice. So Nigel also developed some complications of his non-invasive ventilation. He developed this quite bad abdominal distension. His abdomen was very tight. His bowel sounds were quite tympanic. And it became clear that what he was actually doing is, while he's using the ventilator, he was swallowing air, and that air was collecting, and this created the abdominal distension. This seemed to be quite a common complication of the NIV, and we had to get in touch with respiratory team to adjust his ventilation settings. Also, the appropriate mask changing the mask can sometimes help with this. And in Nigel's case, we also found that venting the feeding tube was helpful to reduce this swallowed air. He also had quite a lot of sialorrhea, which is also a common symptom for our MND patients. He ended up having some Botox as a single dose injection. Botox there's evidence that it can improve sialorrhea and quality of life for up to 4 weeks, but it's a relatively short period compared to placebo. Also, we can try anticholinergic drugs, and hyoscine and glycopyrronium were tried in his case, which was the most helpful. And for some people, they require suctioning. So often this symptom is quite common in MND, and it can be either quite thin, copious saliva or quite thick. And the treatments would be slightly different. With thin saliva, the best practice recommendations is anticholinergics as first line, with Botox and possible even radiation. For those with thick saliva, we wouldn't be giving them anticholinergics, as that can make it worse. Frequent sips of water and also nebulizer can help. Use of mucolytics or sometimes mechanical suctioning. Nigel also had really a lot of difficulty towards later in his disease communicating with, as his bulbar muscles became involved. And so he initially used this tablet with text-to-speech and also had a written communication guide. And then later on, he had an eye gaze computer, so he was able to activate the computer by using the way he used his eyes, which was the only movement that he had. And that allowed him, he really valued that, because that allowed him to have ongoing decisions about his care and the choices. He was able to clarify what choices he wanted and how to manage things, for example, going to hospital, whether he wanted to go to hospital. It did take some time for that for him to be able to use it and communicate with him, but it definitely gave him a voice. And it is recommended that we can refer people early on for communication devices. There's all sorts of options if we do that, where they can use voice recording, maybe get the computer can make the voice more similar to theirs. So there's lots of benefits from introducing and referring people early for communication tools. So this communication tool gave Nigel an option to be really involved in decisions later in life when he was severely unwell. The last few months of life, he had quite a few hospital admissions, and each of those he found quite traumatic, just because removing him from his environment where he's used to the routine, everything's available to him, into a hospital was always difficult. And at that stage, he agreed to having an ambulance letter, which meant that we were just putting in medication so that he could stay at home if it was at all possible, with stat doses of medication. But also he decided he was changing his mind about whether he wanted to go to hospital at all. And that was probably the first time that he hadn't wanted everything to be done. And he had a discussion with that. We had a few discussions with him, and he decided that he wanted to just wait and see how things went. And towards the end of 2021, as I said, these recurrent admissions had become challenging. He also had increasing episodes of shortness of breath, severe shortness of breath, and he responded quite well to managing that with oxycodone and midazolam, which then went to subcut, and a syringe driver was added to manage these symptoms. And then he developed a new infection. His chest x-ray confirmed a right-sided pneumonia. At that stage, he decided not to go to hospital. He had oral antibiotics as a sealing of care, and he deteriorated and died at home. At that point, I'm going to ask Charlie to join us. She was involved with Nigel's care, and I'd love to hear her reflections. Charlie, you're muted at the moment.
Sorry, yeah, Nigel was a special patient for everyone involved. He'd been on our service for 4 years in total. I probably came into the picture quite late on, and he already was being tube fed, ventilated, was a full hoist, having full cares at home. He lived at home with his wife, and they had 2 quite young children, so it was quite a big change in their lives, and their lives really did revolve around Nick. Nick had Nigel, see, I cannot change his name in my head. Nigel had very specific care needs, and we were very aware that his situation was difficult for all the family to manage, and we did trial some respite options in hospice and also in aged residential care facilities, and they didn't go overly well because his needs were so specific, and he just didn't feel comfortable in those environments. So we did a lot of work with Taikura Trust, getting some home respite, which was great. Just thinking about the specific physical needs for Nigel, in terms of his sialorrhea, the glycopyrronium really was the key changer, game changer for him, and that was injectable glyco that he used to put down the rig, or his wife did, so that she used to draw that up in a syringe and pop it down his tube, along with all his other meds, and that was game changing for him, because that was one of his really big issues. He also had a suction machine, which she used to use quite frequently on him, that also helped. I was reflecting on the aerophagia issue for him, which was something I'd never seen before. And he had this massively distended abdomen. And, looking through the notes, I remember us thinking, gosh, has he gone into obstruction? Is he fecally impacted? And we'd abdominally x-rayed him at home, and it didn't look like there was anything going on. And then I remember speaking to one of the GI CNSs in regards to the feed, and they actually provided us with these Farrell bags, which at home you connect sort of one end to the feeding tube and one end to the one to the feeding tube and one to the pump, and it just used to siphon off gas and air as the feed was going in. And I think that was a massive change for him as well, because he was really uncomfortable with that aerophagia, and he had a very, very distended abdomen at times. So a Farrell bag was the change, and I think the district nurses were able to source that through the GI CNSs at the hospital. I know in terms of bowels for Nigel, and I think this is probably similar for most patients who are unable to move out of bed themselves, he wanted his bowels to open on a specific time every day. So we had to sort of adjust his laxatives to help manage that. I think the benefit of having a rig feed going is that you can adjust the fiber content too, which is really helpful to help manage bowels. For Nigel, we did set up a syringe driver at home with some opiates, but sort of early on in the piece, he didn't want any midazolam, even though he was having that subcut, because he really wanted to be present for his family. His aim, which is probably a little bit, maybe a bit different to the first case, was he wanted to do absolutely everything he could to live for as long as he could. And he was diagnosed in 2015 and didn't die till 2021, and he really did everything to be around for his children for as long as possible. He had children who were at quite critical stages of their school life and their age, and he wanted to be able to support them. And I think that eye gaze technology was incredibly important for him, because he was still able to communicate with them, still able to have a laugh and a joke. He used it to do a lot of internet shopping. He would regularly buy new trainers, and I'd go around and he'd have a new pair on every day, and his wife would be like, oh God, he's internet shopping again. But that was able to bring him joy, and he could have some independence in doing that from his bed. I think the issue we got to with him as we sort of entered into that terminal phase and the syringe driver running, was his lines just did not last. And I think we ended up with having to do a staph decolonization on him, because almost every day his lines were becoming infected. And I know Celia spoke about the wounds that people do sustain from NIV masks. That was a big thing for Nigel. He ended up with a nasty infected wound around his neck from the NIV mask, and that was really difficult to heal, and pressure areas, and yeah, so that was a big challenge as well. He had an incredible team, and we had an incredible team supporting us with him. And when we did have those advanced care plan discussions, that him and his wife sort of initiated, because they could see things were changing in him, and they could see that perhaps he was entering into that terminal phase. He really wanted to know what his death might look like, how might it happen? And we sort of laid that out in, I guess, 3 sort of options. One would be an infection that wasn't responding to antibiotics. One would be that he perhaps died from an acute event, and the other would be that he would take his mask off and decide to die that way. And so for Nigel, he, as I say, he did fight to the end. He died of that pneumonia, but he had that NIV mask on until the end, and he died peacefully at home with his family surrounding him. So, yeah.
Thanks, Julie. Yes,
Thanks,
I mean, interesting the thing about the challenge of respite, because I think for his wife, who did absolutely everything there, and it was quite a huge task for her.
Yeah.
It was also, everything also needed a very detailed routine, a bit like the first case. Everything needed to be, so when he did go for respite, when I was looking at the case for this webinar, I noticed that she had written down absolutely everything, including exactly where his hand needed to be placed, and, you know, in extreme detail. And I can see it would have been so hard for her, even though she was under such a lot of stress, to allow herself to let him go to respite.
Yeah, I think I think having that respite at home, it took a long time to find a sort of cohort of carers that were in tune with Nick's need. Oh my God, I'm so sorry.
Don't worry,
With
just
Nigel's needs, with his needs, and him being comfortable with them, knowing that they would be able to respond to some quite, you know, difficult challenges that you perhaps wouldn't expect. And I think for his wife, that took a lot of time for her to actually feel like, okay, I can sleep out of the room tonight because I know that these carers know what they're doing, and Nigel feels comfortable with having them here.
Yeah. Okay. Thank you very much.
Thanks.
For joining us. So I'm going to move on to our third case. I'm going to call Arthur. He was a 75-year-old. He had multiple comorbidities alongside his MND, with diabetes, heart disease, and prostate cancer. And actually, initially, his diagnosis was quite delayed. They initially felt that he had hoarseness of his voice after prostatectomy, and it was attributed to intubation, and then possibly tonsillitis. But he didn't improve from that. And it was 16 months later that he was finally diagnosed with MND after he had an EMG. And at that stage, he also had involvement of the bulbar muscles and pseudobulbar involvement. So he had upper motor neuron involvement affecting his swallowing and speech. He was unsteady on his feet about a month later, sleepy in the daytime, and was trialed on NIV. Just want to reflect on that difference, because the first 2 cases definitely started with limb problems, whereas our third case is starting with bulbar problems. That's a minority of cases, and often the disease is more rapid, and there's an earlier impact both on breathing and being able to eat, and an early need for speech therapy, communication aids. It's also harder for them to tolerate the NIV because of the muscle weakness being where it is. And the median survival would be around 2 to 3 years for those who have a bulbar onset, which this gentleman did. So he had both occupational therapy, physio, and speech language therapy input initially, and all started on non-invasive ventilation in January 2024. He was considered for feeding tube placement, but he decided that that's not what he wanted. And a few months later, he was on NIV 7 hours a day. So again, quite a rapid deterioration for him. He was somebody who had frequent muscle spasms and cramps, and that responded to baclofen for him. So my next poll is around the main goal of enteral feeding in MND. This is something this gentleman decided not to have. Would it be to maintain nutritional status, reduce the risk of aspiration, facilitate medication delivery, increase life expectancy, or all of A, B, and C? you didn't seem to have a choice of the correct answer, which was E, which is all three of A, B, and C. So anybody who put that is correct, but it hasn't shown to increase life expectancy. So there's no survival benefit. So that's just comparing having a PEG compared to a RIG, radiologically inserted gastrostomy. And that's generally for people where their respiratory risk is higher, with a very low FVC, because it may need earlier replacement and the PEG is likely to last longer. So our gentleman, Arthur, found it really difficult to use the BiPAP, which is often common with bulbar weakness. And he used it for 2 months. He found it gave him more difficulty breathing, made him feel claustrophobic. So he stopped using it. He got very quickly more dependent on his family, and his wife, who was a carer herself, stopped work to look after him. He wasn't really able to speak any longer, but could wrote down what his needs and wants were. And at this stage, he was no longer able to be at home alone. Some of the difficulties he had, which was this frequent muscle cramps and spasms, his reduced ability to swallow, and he had chosen not to have a pig in situ, difficulty in communicating, which actually made him extremely frustrated. And there was also, as is often the case, a high level, understandably, of carer strain, and also this sense that Arthur was kind of giving up because of refusing to have the PEG and not wanting to use the ventilation. Whilst he didn't himself have cognitive impairment, I just wanted to raise that issue, as there are not insignificant percentage of people with MND who do have some cognitive or behavioral impairment, and that usually affects their ability to make decisions, their verbal fluency and language, and also their ability to communicate and their apathy. And pharmacological options are not that beneficial, but the use of SSRIs has been recommended, and atypical antipsychotics for something like aggression. We might use something like quetiapine. But for back to Arthur, he at this stage decided, as things were deteriorating and he really had become, I would say that he really experienced a great deal of suffering. He did not want to live anymore like he was. He was in bed the whole time, needed constant cares. Anytime he wanted to get up, it was with a hoist. There was ongoing patient and family distress, especially made more acute because he made a number of requests for assisted dying. And that was particularly challenging for his family, who were against this for spiritual reasons. And then he was then hospitalized for a urine infection, which the family took him to hospital and wanted him to have IV antibiotics and fluids. He was discharged home at the end of March of this year and deteriorated very quickly over the next week to 10 days with severe breathlessness, pain, and it was decided that we would keep him up. He wanted to stay at home. The family wanted to keep him there. And actually, he benefited a great deal from the syringe driver to manage his symptoms, which we were able to do. And he died probably about 5 or 6 days after the syringe driver was set up at home. In some ways, this was a good outcome for him and his family, as it had been very distressing to go through that assisted dying request that he'd made, and that family really didn't feel that they could support him in. Now, as he was entering end of life, that was no longer necessary for him. So I'd just like to ask Ella to join us. Ella's going to reflect a bit on the case of Arthur, who she worked with.
Yeah, thanks, Celia.
you.
And good morning, everyone. I just wanted to start by highlighting the immense respect and admiration that I have for our MND patients and their family. As you said, Celia, it's a heart sink diagnosis, and I feel like with other common palliative diagnoses like cancer, you can have good and bad days, but MND can just be quite consistently and progressively hard. Reflecting on my learning from Arthur is just the importance of advanced care planning. I think as someone's MND is progressing, they're simultaneously losing the capacity to ask questions and effectively communicate as they get closer to end of life. So fear grows at the same time as they lose the ability to voice that fear. As Charlie touched on, I found that people want to know the specifics about death and what they may feel and what it might be like for them. I think being brave as their healthcare provider and asking permission to initiate those conversations, asking people what they're afraid of and educating them about the options that we have at end of life, the medications to manage symptoms and distress, and how their wishes would inform everything that we do. Doing this as early as you can is important, I think, to not let that distress and fear grow in someone. My second reflection would be on respite, which you and Charlie and Celia also spoke about. On one hand, it's so necessary, but on the other hand, it is really difficult to arrange. With Arthur, I actually needed to organise an emergency respite admission because the tension in the house with that assisted dying situation had just exploded. However, he did ask to return home after 3 days, and I think that is just really reflective of the care provided by the main carer, which is just so intuitive. It's unmatched. It's based off feelings and eye movements and the occasional facial expression. It's knowing a person to their core before the disease took hold of them and understanding them on such a level that can't be replicated. You can't teach respite what carers have learned in years of knowing someone before and then during their disease. I would say that the respite was particularly helpful for Arthur understanding the huge role that his wife was fulfilling. As we know with motor neurone, you just lose your ability with every bodily function. It's not just the walking and talking, it's the coughing, it's clearing saliva, it's having a bowel motion. And Arthur's wife had to induce or manage every single one of those bodily functions. It's really true love and unlike anything else. And although respite is life-saving and so needed, the care at home is so streamlined, it's hard to match. So like we said, having a really detailed list of preferences is always needed. But I would always encourage respite for the patient and the carer. It's such an all-consuming disease and an all-consuming role for the carer. So you can see why an MDT approach is so needed. Thanks.
Thank you, Ella. I'm going to ask everyone to join us now, including Jen, our physio, and our other nurses who joined us earlier. Thank you. So we're going to now have a discussion and answer some of the questions that have arisen in the chat. So I'm going to start off because we haven't had the opportunity to talk to Jen, and she's one of the physiotherapists in our rehab team and is a neurophysiotherapist. And I'd just like to ask her to comment on the role of physio in MND. I know it's a huge question.
Thank you, Celia. Good morning, everyone. I think our main role is to try and keep pace with functional mobility, comfort and quality of life needs across the journey of the MND patient. And I think in a nutshell, it's providing a framework. I think therapy provides a framework or scaffolding to work from, and that's looking at very essential things such as equipment needs, wheelchair referrals, providing advocacy, accessing other services such as orthotics requirements, respiratory functional specific equipment requirements, housing modifications, and just keeping pace with the equipment requirements with the emphasis on quality of life. I think, as it goes without saying, it's really important it has to be very individualized assessment, and every case is different. So we really listen to what the MND people need and what they're interested in. as far as exercise and quality of movement goes. So I think we might see exercise as an optional quality component. It's not always for everyone. Not everyone is interested in it. We've got to factor in things like stamina, and they've got to conserve the energy. So I always sort of we always do check with what matters to them and their family and what they're interested in. So the incidental exercise is the key priority, but the overlay on the incidental exercise is quality of movement. And people usually do really respond to that, because we can't decelerate the inevitable of the muscle weakness, but we can influence quality of movement with things such as seat raises so that they can get out of their chair properly, which helps their quads keep working. And they're often very interested to know that if their muscles are working optimally, this can help with their respiratory function. And also their bowel movement, and we include, of course, diaphragmatic deep breathing, and then also with orthotics, that's something that we need to consider for if range of movement and comfort is preserved, then that also influences quality of movement and pain. So muscles biomechanically can perform better if people have things such as resting splints for their upper limbs, resting splints for lower limbs. They almost always need to be, we need to be on high alert for ankle foot orthotics, because as soon as the foot drop starts, then they are off their feet. So we have to prepare and be ahead of the game with referrals, and that has to be handled really sensitively, because we don't want people to lose hope and see themselves in a wheelchair too early. But the reality is that they do need referrals for wheelchairs, quite specialised wheelchairs early on. And that could be through mobility solutions, and anyone has the power to refer. So that can be family, anyone can refer to mobility solutions for wheelchair needs, orthotics, and also we provide advocacy that's often we monitor, and then we sort of respond as required. So we can ask to fast track. I've found that orthotics often might have a 6-month wait list for the usual population, but just recently I've asked for an AFO through Move Me Health, and the person had an appointment within 10 days and supply within 2 to 3 weeks.
Thanks very much.
Yeah, thank you.
I think the point that you made there about advocacy, I mean, I certainly see you and the other physio team doing a huge amount of advocacy to try to ensure that our patients with MND get the equipment and that they need, that you guys will think will make a big difference. And I know it takes a huge amount of time. And time is something that we're pretty short on now as well. So I'm just going to move to a quick couple of other questions. Charlie, how do you think we determine prognosis in MND? We've got about half a minute.
I think probably the dependency on equipment, dependency on non-invasive ventilation, if that's what someone chooses to do. I guess with Nigel, it was difficult because he had chosen all of those interventions, and so for him, the changing thing was his recurrent infections, the fact that he was starting to desaturate even on the maximum flow of NIV, the fact that he was becoming a little bit more sedated. I think he was probably starting to retain some CO2 as well, and becoming a little bit more distressed. Yeah, but in general, it's those functional declines and changes in breathing and secretion management and those kinds of things. So I'm trying to rush through it so you can.
No, that's okay. And I think he had a few hospital admissions, didn't he, towards later on?
Yeah, and that was a challenge because it was COVID and sorts. There is a question in the chat, Celia. I don't know if I think that might have been regarding
that was
to Arthur.
Yes, around whether his comorbidities provided an extra challenge. I don't know what you think, Ella. My feeling about it is it was more that he was fed up with all these things that had happened to him, and it contributed to his suffering because there was so much going on, rather than a particular complication of management per se.
Yeah, and also he was the leader of the household and the decision maker and in charge of that. And so losing all his autonomy was just really difficult.
Yeah. And can you just add just a brief comment, Ella, about what else hospice can offer to support family and carers? And then we'll finish.
I'll try really briefly, but with Arthur particularly, healthcare assistant support was amazing, and that ranged from a cup of tea to and an offload to really practical manual handling support, massage therapy. They absolutely loved. I think sore and stiff muscles is shared with MND patients and carers. And our 24/7 phone line for nursing advice, the wife would call in any time during the night. And I know that was a huge reassurance to her. Of course, the doctors and nurses, and just linking all the organisations together to get the maximum package of care for a person. And that's NAS, District Nurses, Taikora Trust, TalkLink. Yeah, a huge MDT approach, but that's very brief.
No, that's great. That's a lovely way to leave it. Thank you, guys. Thank you, everybody.
Thank you.
Thank you.
So thank you, everybody, for joining us this morning's webinar. Please share your feedback when the link appears at the end. We'd love to hear anything you have to say. This is a reminder of our phone lines. And I'll just end with our karakia. Tūruki whakataha, tūruki whakataha, pomie, huie taikie. Have a lovely day, everyone.